Good morning, Dr. Henrotin. It's an honor and a pleasure to have you with us today here at the Megalabs Connexión LATAM Virtual Summit. Your presentation and your theme have generated a lot of expectation. We are eager to hear you. You have 45 minutes for your presentation, and then if it's okay with you, we will be asking a few questions at the end. Is this okay?
It's okay.
Wonderful. I'll be backstage. If there's anything you need, just let us know. You can start when you're ready. Thank you again.
Dear colleagues, this is my pleasure to join this Megalabs summit and to present you a very interesting and hot topic in osteoarthritis, the role played by inflammation in the progression and the incidence of osteoarthritis. I just would like to remind you that osteoarthritis is the most frequent musculoskeletal disorders, and that at this time, 240 million people worldwide are affected by this disease. Of course, there are more women than men, and the main cause of these disorders are obesity, aging, and joint trauma. We can now define osteoarthritis like proposed by the ORC. Osteoarthritis is a disorder involving movable joints characterized by cell stress and extracellular matrix degradation initiated by micro or macro injury that activates maladaptive repair responses, including, and this is important, pro-inflammatory pathways of innate immunity. The disease manifests first is a molecular derangement, and this is for which we are waiting for soluble biomarkers that could be helpful for the early diagnosis of the disease, followed by anatomic and or physiologic derangements that can culminate in a illness. And it is right that now the FDA recognizes that osteoarthritis is a serious disease. The hallmark of osteoarthritis, this is the cartilage degradation, and the cartilage degradation is driven by the chondrocyte that turn over the extracellular matrix by a good equilibrium between catabolic and anabolic processes. And unfortunately, in osteoarthritis, there is an imbalance between these both metabolic processes leading to the cartilage degradation by metalproteinases, but also by reactive oxygen species that directly degrade the matrix constituent and induce the release in the synovial fluid of a lot of protein fragments, which are considered as the DAMs, the damaged molecular osteoarthritis pattern. If we look now at the story of osteoarthritis and the link existing between the different tissues in the physiopathology of this disease, first, of course, the lesions start at the cartilage levels, inducing the activation of the chondrocyte that undergoes differentiation process. And this stress activates also a lot of a signaling pathway leading to the overproduction of pro-inflammatory cytokines like IL-1 and TNF-alpha, which are probably the two most important cytokines in the OA physiopathology. These cytokines may then induce the activation of the chondrocyte, which become and start differentiating in different phenotypes, and at this time we can identify at least 9 different phenotypes, among which catabolic, hypertrophic, and senescence 1. Chondrocytes start secreting more and more metalproteinases, including ADAMTS 4 and 5, but also collagenase like MMP1 and 3, which directly degrade the surrounding extracellular matrix. And the effect of these cytokines is also a decrease of the synthesis of the matrix constituent, mainly aggregate and type 2 collagen. Recently, it was demonstrated that the chondrocyte of the deeper zone of the cartilage the hypertrophic chondrocytes may produce factors like rankle, which activates osteoclast and bone remodeling. Recently, in my laboratory, we have demonstrated that osteoblasts coming from the sclerotic part of the subchondral bone undergoes a differentiation and express a particular phenotype and produce locally a lot of mediators, including rankle and IL-6, which stimulate bone remodeling, but also VEGF, which can stimulate the neoangiogenesis of cartilage. This point is very important because probably that the blood level at the cartilage levels induce the hypertrophic differentiation of the chondrocytes and the mineralization of the extracellular matrix. Finally, and this is the important point for my lecture today, is that a lot of fragments, the DAMs, the damage-associated molecular patterns molecules, but also patterns associated to senescence and pro-inflammatory cytokines, but also complement factors released from the cartilage may then activate synovial cells, including the synoviocyte, but also macrophage, T cells, neutrophils, through PRR receptors, which are pattern recognitions receptors. And these cells, when they are activated, produce in turn a lot of catabolic and pro-inflammatory factors which can directly degrade the cartilage matrix, but also activate the chondrocyte, and by this way, creating a vicious cycle between the cartilage and the synovial, creating a chronic inflammation, which is, as I will tell you later, is directly related to the cartilage degradation progression. Chronic inflammation is associated with OA progression, and cellular inflammation in acute inflammation is marked by the presence of neutrophils, and neutrophils has been identified in the synovial fluid of osteoarthritic patients, and in the chronic inflammation, the two main cells representatives are the macrophage and the T cells, and the macrophage, which can differentiate it, which are polarized in M1 or M2. This is very important point in the maintenance of the chronic inflammation. It is now well known that the M1 macrophage are the classically called activated macrophage. And these macrophages are involved in the cleanup, in the removal of debris coming from the cartilage, and by this way to prepare the wound healing and the tissue injury remodeling after the inflammatory phase. And these M1 macrophages are activated by cytokines, mainly TNF-alpha and IL-17. And when they are activated, they produce patterns of pro-inflammatory cytokines, TNF-alpha and IL-17. In contrast, the M2 are considered as anti-inflammatory macrophages, which are activated by a totally different set of cytokines, IL-13 and IL-4. And when they are activated, they produce cytokines, but also growth factors, angiogenic growth factors, epithelial growth factors, factors that stimulate cartilage repair and are considered as anti-inflammatory macrophages. The shift between M1 and M2 is a dynamic process which is directly dependent of the environment of the cells and the dose, of course, and the timing of secretion of pro-inflammatory cytokines. What is very important is that it was recently demonstrated that the ratio of M1 and 2 in the synovial fluid is increased in NEOA, and that this ratio is correlated with the radiological severity score, what is so-called the Kelvin and Lorentz score. This is very important because this means that the ratio between the pro-inflammatory and anti-inflammatory macrophages are directly related to the progression of the disease. In summary, what we can say is that the macrophages are until they receive cleaning up signals, which are the dams coming from the degradative cartilage. They are mainly is the M1 form, and they produce a lot of pro-inflammatory factors, but also MMP, which degrade the cartilage and release more and more debris, more and more dams, which can activate the innate immunity through pattern recognition receptors, the PRR. These cells of the innate immunity may then communicate it and present the antigen to the cells included in what is so-called the adaptive immunity. This includes the T helper and the T killer cells. And these cells may secrete cytokines, which in turn may regulate the shifts between the dynamic balance between M1 and M2. If they produce more interferon gamma and TNF-alpha, which promote the polarization of M1. And if there is more IL-4, they are a polarization of macrophage to M2. You have well understood that the target, the therapeutic target, is to stop the cleaning up signals, and by this way to stop the polarization of the macrophage to M1, or also to promote the polarization to M2, and by this way to promote the healing phenotype of the cells and the resolving of the inflammation process. But recently it was demonstrated that inflammation in OA is not only local inflammation, but it's also associated with the systemic inflammation. And the starting point of this story, this is this study. This study demonstrated the correlation, the relationship between the BMI and the risk to have a symptomatic osteoarthritis. What you can observe on this table is that the obese people is a higher risk to develop OA, but that you could imagine because you could imagine that obesity induces more mechanical stress and then induce more cartilage degradation. But what was very surprising in this study is that there was also a correlation between OA and the obesity. What is the relationship between these two conditions? As we know that, of course, the weight cannot directly influence mechanically the OA. And this was the reasons of a research of communication between the fat tissues and the joint. The second important trials demonstrating a relationship between systematic disease and osteoarthritis. This is the ROSE study. In this study, 1,384 patients were followed during 3 years, and the authors tried to find a correlation between the occurrence of knee osteoarthritis and the progression of the knee osteoarthritis and the number of components of what is called the metabolic syndromes associating hypertension, obesity, dyslipidemia, and diabetes. And the X-ray occurrence was defined as people moving from Kerwin ranks below 2 to Kerwin ranks over 2. And the progression was defined as a progression of people with Kerwin ranks 2, 3, or 4. What you can observe is that there is a direct relationship between the number of components of metabolic syndromes and the occurrence, but also the progression of knee osteoarthritis. Therefore, we can summarize these important discoveries leading to the correlation and the relation between the fat tissues, and osteoarthritis. We know that the fat tissue, and mainly the visceral fat tissue, which is inflammatory, secrete a lot of adipokines and cytokines, which go to the bloodstream and may directly affect the clinical, but also the structural progression of osteoarthritis. Of course, fat tissue induces more mechanical stress because it's related to an overweight, and this both process may contribute to the progression of osteoarthritis. What is very important is that now we know that a lot of factors released from the OA joint, released in the bloodstream, like, for example, cytokines or even the TAMs, contribute to what is so-called the chronic low inflammation, also called inflammaging or meta-inflammation. And this meta-inflammation and inflammaging can contribute and to be a risk of development of cardiovascular diseases. And this is exactly for which it was now accepted that there is an increased mortality in patients with knee osteoarthritis. Look at this study. In this study, demonstrated that patients with radiological knee osteoarthritis have an increased risk to die of diabetes, cardiovascular diseases, or renal insufficiency that the patient, the subject, without radiological sign of osteoarthritis. And this risk increase if the diagnosis, the radiological diagnosis, was performed before 40 years old. This is very important because this means that osteoarthritis is also a serious disease affecting the health of the patient. I have tried to summarize all this discovery in this planetarium representation of osteoarthritis. I would like now focus your attention on the blue orbit. The blue orbit, this is what is so-called the biopsychological loops of osteoarthritis. I would like to remind you that osteoarthritis is first a chronic pain, which induces fear of motion, leading to disability, physical deconditioning and sedentarity, leading to anxiety, depression, psychological deconditioning, which are all amplifiers of the pain. Pain induces sedentarity. Sedentarity is a risk factor for metabolic syndromes and obesity. Another important discovery, this is the second orbits, the red orbits, in which, and we know that now, that the metabolic syndromes is a risk factors for the progression of osteoarthritis and synovitis, and then contribute to inflammaging which is with obesity, a risk for cardiovascular disease and early death. Well, another challenge is to identify the good phenotype of the patient to, of course, give them the good treatment. And it is now well recognized at least 6 different clinical phenotypes in the OA population. They are the subchondral bone driven, the mechanical injury driven, the aging driven, the cartilage driven, and even the metabolic driven. And finally, and this is of course this phenotype that is important for our meeting today, this is the synovitis driven phenotype. And in this phenotype, we can distinguish 3 different endotypes. The high level of local inflammation endotype, the high level of systemic inflammation, and also what is so-called the activated macrophage neutrophils. What this means? This means that you have one synovitis-driven phenotype with 3 different endotypes that contribute to explain the synovitis-driven phenotype, and which can be notified using biomarker, because you can see on this slide that each endotype is related with another production with an increased level of soluble biomarkers. For example, the high level of local inflammation is marked with an increase of COL2-1 nitrated, which is a nitrated peptide of type 2 collagen, C1M, a peptide of type 1 collagen, C3M, a peptide of type 3 collagen, hyaluronate, and also endostatin. Well, how can we now treat osteoarthritis in 2021? The core treatments, and I will recall you that because this is important, this is the non-pharmacological treatment, the non-pharmacological modalities, including patient education, physical and occupational therapy, and also weight control wellness. Of course, you know that better than me, is that it's difficult to get patient compliance for these active treatments. The second action is to identify the comorbidities associated with the disease and to treat these comorbidities, because I have explained you before the relationship between the metabolic syndromes and osteoarthritis. Unfortunately, at this time, there are a health professional awareness of the role played by comorbidities in osteoarthritis. Then after, you have the most common treatment, which are paracetamol and the prescribed NSAIDs. And as you know, these drugs are associated with a lot of very severe adverse effects, including gastrointestinal and cardiovascular adverse effects. And this is for which you have to limit their use in the management of osteoarthritis. And finally, on the top of this therapeutic pyramid, you have the surgery, which is only dedicated to the end stage OA process. And between the NSAIDs and the surgery, you have also, of course, the intra-articular steroids injection, the viscosupplementation, the topical NSAIDs, which is very important, but also what is so core, and this is a particular class of drugs, the symptomatic slow-acting drugs in OA, the CSADOA. And in this class of treatments, you have avocado, soybean, and saponifiers, but also glucosamine sulfate and chondroitin sulfate product. How can treat inflammation using these different therapeutic modalities? First, I can treat inflammation locally by application of continuous cold therapy or by the application of topical NSAIDs. I can also treat inflammation using orally NSAIDs or what I told you, the symptomatic slow-acting drugs, or food supplements like food supplement containing curcumin. And finally, you have intra-articular treatments, the corticosteroids, but you have, of course, to limit the number of injections per joint to avoid acceleration of cartilage degradation. And more recently, the technique of the PRP, the plasma-rich, the platelets-rich plasma. But what is very important to keep in mind is that you have to limit NSAIDs consumption in OA management. Why? Because OA is a long-term progressing disease over more than decades. OA occurs in aging people with potential comorbidities that may be affected by NSAIDs intake. It was demonstrated that NSAIDs has a low effect on OA pain and function. To give you an example, the effect size of NSAIDs is 0.25, while the effect size of non-pharmacological treatment like exercise therapy is over 0.5. Another important point is that NSAIDs consumption is associated with severe adverse effect and that there is a high risk-benefit ratio in the long-term use of NSAIDs. This is exactly what it says in the ORC and the recent ORC recommendation. And these recommendations are very important because this is the first time that we give a recommendation according the phenotype of the patient. And in this recommendation, the expert have classified a patient according the presence or not of comorbidities, and they have distinguished 6 different phenotypes: patient without comorbidities, patient with gastrointestinal comorbidities, cardiovascular, friendly aging people, and patient with widespread pain depression. And they give very specific recommendation according these different phenotypes. And what is the place of NSAIDs and corticosteroid in this recommendation? You have here a table summarizing the recommendation. And the most important and the key message that I would like you take with you at home is that topical NSAIDs, but not oral NSAIDs, were strongly recommended for patients with knee OA. The use of oral NSAIDs was conditionally recommended for individuals based on the presence of potential severe adverse effect, and is conditionally recommended for knee OA patients who do not have comorbidity condition. NSAIDs of any class were not recommended for patients with cardiovascular comorbidities and in patients with Fragile. If required, based on the good clinical practice, please use NSAIDs at the lowest possible dose and for the shortest possible duration. And finally, one word on the intra-articular corticosteroid. The intra-articular corticosteroids are conditionally recommended and not recommended for widespread pain and depression group. Well, this means that the use of NSAIDs and corticosteroids is very limited in the treatments of knee OA. Therefore, we need for alternative. One alternative, this is PSK 300, which is composed of avocado and sunbean unsaponifiable fraction of fatty body of avocado or soybean. And the capsules of PSK contain 100 milligram of avocado unsaponifiable fraction and 200 milligram of the soybean unsaponifiable fraction. And what is very important is that the composition of these avocado soybean unsaponifiables is a particular and patented formulation containing well-defined components, active components, coming from the exclusive manufacturing method. What this means? This means that you cannot extrapolate the results that I will show you in my next slide to other avocado soybean unsaponifiable containing products. This is very important. Well, another important point is that PSK 300 has a well-known mechanism of action. And this mechanism of action was studied in my laboratory, and we have investigated the effect of PSK 300 on different cell types. I will show you only the results coming from chondrocyte culture. In this part of our preclinical research, we have cultured chondrocytes in the absence or in the presence of PSK 300, and the human OA chondrocytes coming from patient candidate to proteases were cultured in alginate beads. Why in alginate beads? To avoid chondrocyte dedifferentiation in fibroblasts. You know that when we culture chondrocyte in petri dishes, they differentiated in fibroblasts and lost their chondrocyte characteristic. This is for which this kind of culture are very precious and important. Well, what we have done is that we have isolated chondrocytes coming from OA cartilage, and we have mixed this chondrocyte with alginate solution, And we have eluted the solution as a dropwise manners in a solution of CaCl2. And by this way, the alginate gellify and forms beads in which chondrocytes were entrapped. Well, the beads with the chondrocytes were cultured during 12 days in a well-defined culture method, and after 12 days of treatment with PSK or not, the beads were dissociated with citrate, and the different fraction collected by centrifugation, and by this way we could measure in the supernatants of the culture, but also inside the beads, different mediators like the aggregan, like TGF-beta1, MMP3, which is the stromelizine, or type 1, which is an inhibitor of stromelizine and metalproteinases. By this way, we have demonstrated that PSK300 may increase aggregant in a dose-dependent manner, but also increase TGF-beta1, which is a growth factors involved in the cartilage repair in the synthesis of the extracellular matrix of the cartilage. And this is very important because this demonstrates that the drugs may stimulate the factors and involve in the synthesis of the extracellular cartilage matrix. Interestingly, in the context of my talk today, is that we have demonstrated that PSK300 is also a potential inhibitor of inflammatory mediators like the nitric oxide. I hate that it's a chemotactic factors for cells of the high innate immunity, for example, or neutrophils, and also decrease the production of IL-6, which contribute to the systemic inflammation. And finally, we have also observed a very important effect on MMP3, which is the stromelizine, which directly degrades the aggregan, which is one of the major components of the extracellular matrix of the cartilage. This is another important result, is that we have demonstrated that PSK300 may counteract the effect of IL-1 beta, which I remind you is one of the key cytokines involved in the dysregulation of chondrocyte metabolism. You can here observe that after IL-1 treatment, you have a decrease of aggregan synthesis. This is the blue and orange curve, comparing to the chondrocyte which were not treated by IL-1, the green line. But what is important is that the orange line, you can observe that after 9 days of treatment with PSK, there is a recovery of the aggregan synthesis. This means that the inhibitory effect of IL-1 on aggregan synthesis was totally reversed by the treatment with PSK300. So we have demonstrated that PSK300 have a well-known mechanism of actions, but what is the clinical efficacy of this treatment? The first study I would like to share with you, this is this study published by Emmanuel Maheu and colleagues, demonstrating the effect of PSK300 on the Lequen's functional index, which is a French algo-functional index. In this study, which is a randomized double-blind placebo-controlled study, including 162 patients with knee or hip osteoartritis and with moderate radiological severity of the disease, it was demonstrated that PSK rapidly after 1 month may improve the algo-functional status of this patient, and that the effect increase with treatment duration. And after 6 months, you can see that the magnitude of the effect of PSK300 treatment is very significant comparing the placebo group. But what is also important in this study is that the authors is follow to monitor the effect of the treatments 2 months after stopping the treatments. This is represented by the orange box. And what you can observe is that this effect, this improvement is continue follow even after stopping treatment with piasketin 300. They have also investigated in the same study the effect of piasketin 300 on the global spontaneous pain and also on what is so-called overall functional disability recorded using a visual analog scales. And again, what they have observed is that you have a rapid effect which amplify with treatment duration and which is remnant even 2 months after stopping the treatment. They have also recorded the success rate which was defined as an improvement of at least 30% of the Lecan index and an improvement of at least 50% of the pain, a reduction of pain of at least 50%. And what you can observe is that the number of patients, the percentage of the patient which reach this success rate criteria increase with treatment duration and continue to increase even after stopping the administration of the drugs. This means that piasketin 300 had a remnant effect. They have also recorded the consumption of NSAIDs, and I remind you that one of the objectives of the treatment of OA is to reduce the consumption of NSAIDs to avoid adverse effect in aging patients with comorbidities. And on this slide, you have the percentage of patients with NSAIDs re-intake after 45 days. And you can observe that the number of patients, the percentage of the patients that reintake NSAIDs after piasketin, during piasketin treatments, is lower in the group treated by piasketin comparing to placebo, which is represented by the gray columns. All these very interesting clinical effects are summarized in this meta-analysis, including 4 industry-sponsored RCT, including themselves 272 patients with HIP-OA and 392 patients with knee-OA. And these patients in these 4 studies have been treated with the recommended dose of 300 milligrams per day and in average during 6 months. And what you can observe is that the effect of piasketin on pain represented by the effect size is important, correspond to 0.39, and the effect on the Lecan functional index is 0.45. I remind you that the effect size, this is the magnitude of the effect of the treatments compared to the placebo group. And what is important is when we place this value in comparison with conventional treatment. I remind you that the effect size of NSAIDs is in mean 0.37, while piasketin, this is 0.39. What this means? This means that the effect is over the effect size of NSAIDs, but you have, and I will demonstrate you that later, without side effect. And if we compare the effect size with those obtained with chondroitin sulfate, glucosamine, or a mixture of glucosamine, chondroitin sulfate, or even glycerin, you can observe that the effect size on the pain is higher than the effect size observed with other well-known treatments of osteoarthritis. The last study I would like to share with you, this is a study investigating the effect of piasketin 300 on the OA progression evaluated by X-ray by measuring the joint space narrowing. In this randomized double-blind placebo-controlled study, included patients, more around 400, were aged between 45 to 75. They meet the radiological and clinical criteria of the American College of Radiology for hip osteoartritis, because the patient included in this study were only hip OA patient. They have a pain for at least 1 year and a local functional index score between 3 to 10, and with localized superolateral or superomedial joint space narrowing with minimal joint space with adding inclusion time between 1 to 4 millimeters, and the patient were treated with piasketin 300 milligram each day during 3 years. This is a 3-year study to record the evolution of joint space narrowing. Comparing the two groups at the end of the follow-up, no significant difference was observed, but a secondary analysis has demonstrated that the percentage of patients with a progression after 3 years over 0.5 millimeters, which correspond to a rapid progressive patient, you can observe that this percentage is higher in the placebo group than in the piasketin treating group, meaning that in this particular group of patients, piasketin may slow down cartilage degradation. Finally, the endpoint. This is, of course, the tolerability, and this meta-analysis summarized all the adverse effects recorded in all clinical study about piasketin 300, and you can observe that piasketin 300 is no more adverse effect than the placebo. Well, we can then summarize that the effect of piasketin 300 and the take-home message were that first, piasketin 300 is a unique formulation with well-identified mechanism of action. This means that the clinical effect, and even the in vitro effect cannot extrapolate to other formulation. A strong clinical evidence, this product is supported by a strong clinical evidence demonstrating efficacy on pain and function, and also efficacy to reduce concomitant NSAIDs consumption, and with a potential structural effect. And this is probably the most important, with a good tolerability profile, suggesting the long-term administration of this product. And I remind you that piasketin 300 is recommended by URAR in the management of knee osteoarthritis. Well, what will be the perspective to treat synovitis driven away in the future? I know that there is in preparation a new biotherapy using monoclonal antibody neutralizing both IL-1 and TNF-alpha. There are also biomaterials, very small beads, releasing NSAIDs, a long-term release of NSAIDs and corticosteroids. There is also gene therapy in development using an adenovirus for IL-1 receptors antagonist that will allow a sustained release of this neutralizing product in the joint. There is also some stem cells therapy, because we know that stem cells could be immunosuppressive, and also a microvesicle or exosome released by these stem cells that could have, according the microRNA contained in this vesicle, could contribute to cartilage repair, but also to control inflammatory, and might need to promote the resolving of inflammation. Thank you very much for your attention. I remind you that the Osteoarthritis Day is next September 17, and please promote this event in your country. Thank you very much.
Merci beaucoup. Thank you so much, doctor. It was very, very interesting to hear you, especially for me. I am not a doctor, but I was mesmerized by the amazing advances. Do you mind if I ask you a few questions?
Yes, of course.
The first one would be, at what moment of osteoarthritis do you usually use symptomatic slow-action drugs?
Personally, I start earlier possible the treatment with Cisadoa, and so generally I prescribe Cisadoa in combination with non-pharmacological modalities, including exercise therapy, but also weight management and information and education. And I evaluate my patient 3 months after initiating the treatment. And if the treatment is efficient on the patient, I continue to prescribe avocado, soybean, and saponi fibers, or another Cisadoa for next 3 months period.
Okay, thank you very much. Thank goodness I love avocado, and I'm sure many people here that use that a lot. So it's a good complement in our nutrition. Second question, doctor. What could you tell us regarding those products that claim to have ASUs, and even those that have combinations with other ASUs?
Sorry, can you repeat the questions?
What could you tell us regarding those products that claim to have ASUs, and even those that have combinations with other ASUs?
Yes, definitely we cannot compare the results and extrapolate the results I show you today with other preparation. And why this is clear is that piasquidin, the ASU containing in piasquidin 300 correspond to a particular formulation containing a particular amount, a specific amount of different components like sterols, for example, or tocopherols or other product. And you cannot extrapolate this product coming from a particular extraction and manufacturing process to another product, because the posology, the formulation, the content of active product is not the same.
Okay, thank you so much, doctor. We have 2 more questions. The next one being, could you delve a little bit more about the latest advances in the treatment of osteoarthritis?
Yes, I think there are a lot and panels of very interesting research way at this time. I explain you the potential role of stem cells coming from the fat, but perhaps also in the future stem cells coming from the muscles to treat osteoarthritis and mainly synovitis. And what could be interesting is to mix, for example, treatments like piasquidin 300, which don't regulate the production of pro-inflammatory, with stem cell therapy, because we know that the anti-inflammatory phenotype of stem cells is dependent of the pro-inflammatory environment, the pro-inflammatory cytokines environment of the cells. Therefore, we can imagine in the future a combined therapy using anti-inflammatory product like piasquidin 300 with stem cell. Another interesting way, this is the biomaterials that slow release anti-inflammatory product like NSAIDs. By this way, you limit, of course, the adverse effect, because you limit the release of corticosteroids or NSAIDs locally, and by this way you decrease the systemic effect. This is also a very interesting way. And finally, one word of gene therapy. I think that the aim of gene therapy is to modify the expression locally of anti-inflammatory cytokines, and the aim is to induce the long-term secretion of anti-inflammatory mediators by synovial cells, for example, and by this way to counteract the pro-inflammatory mediators released by all the joint cells.
Doctor, thank you so much. You have been really amazing. And I would like to invite all the people that are watching us at this moment, if they have any questions, they can send us an email and we will get them to you. Is this okay?
With pleasure. You are welcome.
Thank you so much, Doctor. It's been an honor and a pleasure to have you with us today. Thank you.
Thank you.